So it's I was given this task to tell you about ESD for colorectal recurrence, and it's probably not the first choice that we are having, and there is very, very little evidence behind that. So I will just I've prepared some videos, and I've tried to summarize really briefly what we know just on one slide, because I think that this is I mean, the best evidence for the moment. I mean, what we can achieve in terms of ESD for recurrence. It comes from Noriko Suzuki. So this is a nice study which shows us on the right hand side a comparison of a success rate for recurrent cases, relatively infrequent 30 cases, as compared to a big cohort of other colorectal ESDs. And obviously the tumor size was comparable in this study. Median procedure time, I mean, this is a Japanese hand, so very quick for both ESD procedures, but significantly longer. And this is obviously something that you'd expect. And then also some of the downsides. So obviously, even in very experienced hands or expert hands, en bloc resection rates are significantly lower, R0 resection rates are significantly lower, and curative resection rates are significantly lower. Though the complications doesn't seem to be so much of a problem. So the problem appears to chop off the entire lesion in one single piece, and we know whoever tried to resect a recurrent lesion in the colon or rectum with ESD knows that it's quite tricky to get it done. And I will start with the first case, which is I would say a special one, because I mean, it's recurrent, and it's in ulcerative colitis, and it's full circumference. Right. So this is something which is not very typical, but honestly speaking, I treat most of the recurrences myself with EMR, CAST, and some other techniques. But this kind of a very difficult lesion, I think that can be tackled, especially in the rectum, only with ESD, because otherwise you won't be successful.
So FTRD is believed to be the option tree, and I really do believe that that's option tree. And this is my conclusion, but nevertheless. So for those who don't know what is FTRD, so it's a cap adapted on the tip of the scope with a Novesco clip and a TSC clip pre-mounted around of the cap with a snare inside, and you can use a grasper to get the lesion inside, release the clip and cut the lesion out. When the clip is released, it's released and there for months. And you have to keep it in mind. So are we believer or not in that system? In God we may trust, all other must bring data. So we will see what are the data about this. The data on FTRD in recurrence after colonic polypectomy are scarce. We have that study published 5 years ago, one center study, retrospective study coming from Germany. And we see that the specimen size of the recurrence was 25 millimeter. We know that with the FTRD, we can go up to 30 millimeter according to the company. Not every lesion was accessible with the device, and that could be a problem with that system. The R0 resection was 80%, but a high risk, not a high risk, but a significant risk of perforation requiring surgery, and a risk of bleeding also. If we go to comparative study, we have this Italian study comparing the usefulness of FTRD versus ESD for challenging colorectal lesion. We have in that study, we have a subgroup with recurrent scar, and we have 30 patients randomized between ESD and EFTR. We have also this study coming from France, and this study showed a retrospective analysis of two historical cohorts, ESD and FTRD. In this study, we have almost 100 patients treated for residual neoplasia with FTRD. if we compare the results between the Italian randomized control trial and the French cohort, we have also a small specimen size, less than 20 millimeter. The access to the target was okay, but not in all the cases feasible. The mean procedure time was the same, and the technical success and R0 resection rate was a little bit better than the one described before in the German and Dutch database.